there was this one quote and it just like hit me. Clinician said to patient, cleaning is what you do at home. What we do here is scaling. And I was like, oh,
yeah,
mic drop.
It's a good one.
Right?
Yeah, that's
cleaning
a good
is what you do at home. I'm like implementing this.
What's up, dental peeps? It's your girl Irene here with Tooth or Dare podcast. Hold on to your suction. It's about to get slippery.
Welcome back to another episode of the Tooth or Dare podcast, peeps, with your peep Irene, and joined by the lovely
Vic.
Hey, friends. Welcome back to Op Talk. We're talking SRP. We have a 2-part episode for SRP because this question is deep and juicy and intricate. So intricate that Vic needs to hold a laptop to read it because it didn't fit on her card, and my card is just like basically empty anyways. Decoration. Hit it, Vic.
I'm just a girl.
I'm just a girl.
Okay, question is, as a dental hygienist, when treating deeper periodontal pockets with active periodontal scaling and root planing, we aim for pocket depth reduction and stability. But at what point do we consider these pockets to be non-active? Is it when stability is achieved or when pocket depths reduce to a certain level? And at what point, if any, would we adjust the frequency of periodontal maintenance appointments? Are we always keeping this patient on a 3-month interval? Or is it a threshold of stability or pocket depth reduction that would warrant a longer interval? That's the first part.
I love how detailed this question was.
Yes.
Is this in the clinical questions post?
It's either in that one or the dumb questions. I think it's the dumb questions.
If anyone ever wants to ask a question, there are 3 pinned posts on the top of my Instagram. It's where all of these questions, and then I also do the answers in there too. There's a clinical question one, then there's one that just says no dumb questions that could be about anything. Mm-hmm. And then in the middle, there's one that says resources. So I did respond to her here. And it was a long response. Yes. And I do want to answer it here before I want to read this answer.
Yeah, okay.
So that was the first part of the question about reducing depending on the patient, possibly extending to a 4 to 6 month. Is that the first part that you have there?
Yeah. Cool. Always keeping this patient on a 3-month interval, or is there a threshold? Yeah.
Got it. Okay. So I, in here, referenced a resource where I got my answer from, which corroborates my recommendations. So if you want that resource, just send me a DM. But you can also screenshot the comment and then just copy it from your phone. So what I wrote was, great question. Let's break it down. So as per AAP, there are 2 possible categories that a periodontally involved patient would fall into and be deemed quote unquote healthy. So number 1 is periodontal disease stability. Which is divined by the state in which periodontitis has been successfully treated through control of local and systemic factors, resulting in minimal BOP, optimal improvements in PPD and attachment level, and a lack of progressive destruction. Or 2, periodontal disease remission, which is control is defined. It's divined by a period in which the course of disease during the treatment has resulted in a reduction, although not totally resolving, of inflammation and some improvements in PPD, periodontal probing depths, and attachment levels, but not optimal control of localized or systemic contributing factors. So that would be your patient that may have cardiovascular disease, diabetes, smoking, a variety of contributing factors. So you've controlled pocketing, but you haven't controlled perhaps the risk factors. And essentially you're looking for no or minimal bleeding, no inflammation, stability of the probing depth. So you may still have 4s and you may still have 5s. Hopefully those 4s and 5s are not bleeding and they're stable. They're not changing. As for treatment interventions, I tackle those in different ways, which I know we're going to talk about that in this episode and also in part 2. Yeah. So I think you need to define which of those 2 you have.
Yeah. Before you continue.
Yes. So did that answer part of her question?
Yes.
Or most of it? So like how do you?
Yeah, because you determine when it's non-active, stability. Yep.
Yeah. And the hardest part is when you're seeing a new patient that you've never seen before.
Yeah.
And the previous office didn't share the periodontal probing with you. So then you know whether they're stable or not. So there's a very particular patient who I talk about in my Perio lectures who signed a media release form for this exact reason. I like pleaded with her. I didn't have to do much convincing, but she was referred to me by a hygienist, by a different hygienist who works in a practice in Toronto, who was having a really hard time stabilizing her perio because they didn't have the tools in the office. They were doing your standard SRP with just instrumentation. And from what I understand, not great instruments. And she was not able to catch the disease. And that's kind of how she phrased it. She's like, I feel like I was running a race and periodontal disease was like 2 steps in front of me and I'm running as fast as I can. And I just can't catch. I'm hitting its ankles, but I'm not catching it. Yeah. So she referred this human to me, which was a kind of interesting thing that happened. And this was right at the beginning of me opening. So it was like 2020. But she is that human. She's the patient that is stable in her 4s and 5s now. And luckily I was able to get the perio probing from this hygienist that referred the patient to me. But otherwise, how do you know?
Yeah. You don't.
You're starting from scratch every time this patient becomes a new patient somewhere else.
Yeah. That's one of my pet peeves is when offices don't send probing tests.
They're like, oh, well, it doesn't matter.
Yeah. Yeah.
But it so does matter.
It does. Yeah. The only other part was, are we always keeping the patient on a 3-month interval?
What do you think? What's your instinct? Let's say it together. Ready? 3, 2, 1. No. Yay! We did it.
Yeah.
I call it graduation.
Depends. Yeah.
What do you call it?
I don't call it. I don't know.
Well, I call it graduation.
I don't have a word.
I do. I like to think of it as, so there's like 3 different factors, right? There's the in-office factors, my controllable factors, things that I can control, which is biofilm, soft and hard deposits, and restorative to a certain extent. Certain modifiable factors that I can't control would be occlusion. And that's like ortho-related traumatic occlusion that might be contributing to some of these deeper pockets, and patients that are not inclined to fix the occlusion. So like that's, and then the systemic factors. And then there's the home care factors. Like if all goes well here, then what? Yeah. Because someone said something the other day. I watched this like spear video. We do this like spear study club at my office, which I'm sure you'll hear about on my socials soon. But we watch videos, like tutorial videos, and then we meet once a month and then we talk about the videos. In a spear video, there was this one quote and it just like hit me. Clinician said to patient, cleaning is what you do at home. What we do here is scaling. And I was like, oh,
yeah,
mic drop.
That's a good one.
Right?
Yeah, that's
cleaning
a good one.
is what you do at home. I'm like implementing this. And I don't want to be like, cleaning is what you do at home, like mean.
Yeah.
But definitely cleaning is what so are they taking the recommendations that were implemented and doing them?
They need to understand the difference of like what we do here and what needs to be done at home. Yeah. And it has to be a collaboration for it to work. Yeah.
I use this analogy sometimes with patients too of this like graduation. Most people have had an allergy test done before, like a food sensitivity test, where they eliminate everything from your diet. And like a few years ago, I struggled with chronic hives, like chronic idiopathic urticaria, it was called. And they thought that maybe it was food related. They also thought it could have been related to my N95s. So I did multiple tests where they eliminated so much stuff from my diet. I had little patches stuck to my back and on my arms. So all I could eat was potatoes and meat and rice. It was like basically on the bad dog diet, like the diarrhea dog diet. And then they slowly started adding things to my diet and like tomatoes, nightshades, eggplant, all of that kind of stuff. Those are highly allergic. So I say that to a patient, it's like, we're basically putting you on this like elimination, removing everything. And then I'm slowly going to incorporate things back in. So I go from a 3-month maintenance. I go from SRP, 4 to 6 week eval, and I'm debriding at the 4 to 6 week eval. And then I'm going into the 3-month mark. And then if all goes well at that 3-month mark, and we'll talk about like my how I'm determining it. Actually, we're talking about that now, right? So 10 and 10. I look at 10% bleeding and 10 or fewer sites of 4 millimeters or fewer. That's my benchmark of health, or if not health, but if I've been successful. So in this case, in this human, I'm looking at her perio probing, and it says it at the bottom here, like my open dental perio charting. I wish I had like a Florida probe or something that was a little bit more intricate, but future Irene might. But I look at the probing, like the bleeding. So like this human went from 60% to 40% to 32% over the course of 3 years.
Yeah.
So like it's getting better,
Yeah.
but not quite where I want it. So
No.
she's not going on a 4 month anytime soon. Like she's going to continue to be on this 3 month.
Yeah.
If someone goes from SRP, 60% bleeding sites, and then they come back 4 to 6 weeks later, I reprobe and bleeding's down to like 10%, like start with 3 and then see what happens next.
And I think that's so important to remember, not to switch the interval too soon. It needs to be monitored before it's switched, and certain things need to be met before it's switched. I think too often people come in for an SRP, they do, a year of 3 month scales, and then the patient, I don't want to do this anymore. So then, okay, we can bring you to 6 months. There's been some improvement with the buildup, but that's not the indicating factor here. There's so many other factors.
Yeah. Some very smart humans say that they're not terribly concerned about calculus. It's the biofilm and the soft deposits that are the most concerning. So if I have someone that has localized, mineralized biofilm, which is calculus, but doesn't have generalized biofilm, I'm on board with that, because most of the time the calculus is very soft and it breaks off easily. And it could be, an embrasure thing, or on the lower linguals where you've got salivary glands with high calcium in the saliva. I'm more concerned about the soft, squishy stuff instead of the really hard stuff. Yeah. That makes sense.
I agree. Yeah.
Yeah. So that's that. Is there any more to that question?
There is another part to it. What is different in your active periodontal appointment versus where the patient is considered stable or in remission, which we'll cover in the next one.
Yeah.
And then, so the second part of her question is for the next episode.
Got it.
Yeah.
I'm just going to go back and just read this real quick, just to make sure I didn't miss anything in my mind. Basically that was just like adjusting the frequency. Yeah. And I try and go really slow. Yeah. We also treatment plan out the whole year. So that's another thing that helps. Think of all of the questions and the complaints patients make of why they say no, and work backwards. So like if you write down, well, I don't want to come in frequently because of time. I don't want to come in frequently because of money, because either my insurance doesn't cover X amount of appointments or X amount of units of scaling. We treatment plan it out. So at the new patient examination or their first visit, I mean, the beauty of my office is every new patient was a new patient. So we set the expectation. Yeah. But if this is something that you want to change, so someone's looking to revamp their perio protocol for 2025, have those things in writing, and maybe even on a laminated sheet where you can write on it and then erase it with a alcohol and permanent marker, where it's preset and pre-planned. Yep. Like we're not doing something new for everyone every time. Like we've done SRPs 1,000 times. Yep. You might add something to it, but generally speaking, your frequency and your timing and the cost is going to stay the same. So if you know every 3 months, my 3 month appointment is $400, let's say, then that's, and it's X amount of scaling units, then that's what it's going to look like. And I call it quarterly visits, Q1, Q2, Q3, Q4. So your Q1 visit, Q2, it's 4, 4, 4, 4. I know it's going to be $1,600 for the year. Your insurance may cover 80% of that, whatever. Yep. But that's the commitment that you're getting in your treatment plan. Your treatment plan doesn't stop at SRP. Your treatment plan is the entire maintenance of it. You're going to like get cosmetic surgery done, your nose, your boobs, your whatever. Like your treatment plan doesn't end on your surgical date. You have a post-op visit. You have a 1 year visit. You've got like all of these other appointments that you need to do. You need to maintain things with skincare, with whatever. Like you're getting LASIK eye surgery. It doesn't stop on the day that you get your eyes done. Yeah. You've got drops to do every 2 hours or 4 hours or whatever. Yep. I don't know why we're very like
It's almost like
That-
we just take it.
day by day.
Yeah. Appointment by
slow.
appointment. Yeah.
We'll go slow.
Yeah. But yeah, that would help the patient to treatment plan it for the entire year. They know what they're getting themselves into.
Yeah. And it might seem a little overwhelming
Mhm.
if it's sprung on them.
Right.
But I mean, I'm a planner.
Yeah.
You're a planner. Most of our patients are planners,
Yep.
I'd say. At least my demographic is.
Yeah. Mine,
Some maybe
not so much,
you were in
but
more of
yeah.
a rural area.
Yeah.
So what do you think your rural area patient would have liked?
I do actually think they probably would have liked to see it all laid out. The difficulty is a lot of them didn't have the funds, or their insurance would only cover 4 units per year.
Mm,
So they're basically, who's going to pay for that?
Yeah.
Well, I mean, now I guess there's the CDCP that some
Yeah.
offices have.
and you can request more units.
Yeah,
too, like
yes, exactly. Yeah.
ODSP.
We would always do
Yeah,
that.
request more
Always,
units.
yeah.
CDCP also lets you request more units.
Yeah. But for the most part, we got a lot of, they would agree to doing the 3 months and then just cancel their appointments.
Yeah.
Day of, right? And
But
then
you-
not,
But you did your work. Like
Yeah.
you did your treatment planning.
Yeah.
You were like, yeah.
this is what you need because of this, this, and this. If you don't take care of it, it's going to progress, give them all the pros and cons.
Yeah.
And then ultimately it's their decision, right?
Yeah.
But
Yeah, absolutely.
it is difficult, I would say. I do find, like, from working in Toronto and then also working in a real rural area, patients are more accepting of treatment plans in this area than a rural area.
Yeah.
I've found.
Yeah. Well,
Yeah.
money.
Yeah, exactly. Yeah.
Homes are much more expensive around here, which tells you, kind of the demographic of what that looks
Right.
like.
Right.
We're also underutilizing the value of dental hygiene schools.
Definitely.
And I mean, that's part of my treatment planning. If someone says it's a money thing,
Mm-hmm.
then immediately I'm going to, well, let's alternate between here. Let's maximize your coverage here. And then in between, you're going to a dental hygiene school. And I have a draft letter
Yeah.
that I write and I give to the patient. And I'm like, could you imagine if you were in dental hygiene school,
That'd be great.
and you get a letter written to you
Yeah.
from a practicing dental hygienist about partnering and collaborative, like I would have cried.
Same.
I would. And if as the instructor,
Yeah.
could you imagine your student comes to you and you're like, at that point you were Sibley, but you're like, Miss Sibley, I got this letter from my client,
Yeah.
from a dental hygienist that they go to. Like I would have just been like,
yeah, it would have been awesome.
bless her
Yeah,
heart.
exactly.
Yeah.
But some places don't have that opportunity. Here, there's lots, right?
Yeah.
Where I was practicing, specifically in Perry Sound, there's no hygiene program. The closest one is either Barrie or North Bay.
Yeah.
So patients also don't want to drive,
True.
right?
Train.
But in
Yeah.
cities,
Yeah.
definitely utilize it.
Yeah.
That's awesome.
Yeah. Yeah.
Even-
It's tough
yeah.
for rural peeps.
Yeah.
And that like, I wish our government would have more community services. And I mean,
Yeah.
there are many like mobile
Mhm.
dental hygienists that are trying to partner with government programs
Yeah.
to get care. But like, it's
Yeah.
just,
One day.
we're going to make Canada healthy again,
Yeah.
make America great again or healthy again. But we're going to start with removing fluoride as opposed to giving dental care, whatever. I'm just,
Topic for another day.
someone's going to come at me for that
And
one.
that's the end
That's
of
the end of that
our
one?
episode.
All right. So part 2, we're going to talk about the how.
yes, definitely.
Irrigation.
and what?
Antimicrobials,
Yep.
minocycline, types of SRP, laser, like the nitty gritty treatment planning stuff in part 2. So stay tuned for part 2. Okay. Till next time.
Bye.
Peace out, peeps. Bye.